Welcome to episode 26. Today on Beyond the Thyroid podcast, we're going to discuss why endocrinologists and other strictly mainstream physicians don't seem to be very successful with helping people manage their Hashimoto's disease. So if you're like many of my thyroid clients, when they first come to me, you may have waited months for an appointment with an endocrinologist, hoping this doctor would be the one who could finally figure out your fatigue and your other thyroid problems, only to be disappointed. Come back when your TSH is abnormal, they might say. So if you're like most people with Hashimoto's, this treatment strategy may leave you hanging. So come take a listen as we compare and contrast this approach with a philosophy that's informed by years of clinical experience as well as personal experience. Before we get started, I am now offering a brand new signature program for people who aren't sure their thyroid is actually causing their symptoms and want to get testing and analysis without the higher price point of a comprehensive one-on-one evaluation. It's called the Thyroid Checkup, and more information and the sign-up page is available at www.danagibbsmd.com/checkup. So let's go. You're listening to the Beyond the Thyroid podcast. I'm your host, Dr. Dana Gibbs. I'm an ENT surgeon and hormone specialist. For years, I struggled with my own unrecognized thyroid problems before and even after I was regularly performing thyroid surgeries. Then, one day, I learned something that turned my health around and opened my eyes to the limits of mainstream medicine in treating more subtle thyroid abnormalities. I spent the next 20 years fine-tuning my hormone expertise in disorders like Hashimoto's disease, perimenopause, and stress-related illness. Come join me as I share this new approach to hormones that empowers you to take control of your own thyroid and hormone imbalances. Let's dive in. I have a really exciting announcement. Because up to 50% of people who suffer symptoms of low thyroid, the low energy, the weight gain, the gut problems, the thin hair, dry skin, will be told by multiple providers that there's nothing wrong with their thyroid before they get a diagnosis because they have normal TSH, I am going to build a new offering in my practice that I'm going to call the Thyroid Checkup. Because this circumstance is so discouraging and frustrating when you know you don't feel like your normal self. I know because it happened to me and hundreds of my clients. So if that's you, what you need is access to advanced thyroid lab testing and analysis by an experienced and qualified specialist who goes beyond guidelines-based thyroid care to help you finally know where you actually stand in regards to your thyroid. This will be a small group program with direct access to me, where I'll help each person get answers about their thyroid status and next steps to recover their energy and vitality. So if you want more info about this, go to www.danagibbsmd.com/checkup to get the earliest notification when I open this program. It's going to be soon, so don't wait. Hello, my friend. I am so happy to have you back. And if you're new to the podcast, welcome. Let's get started with today's topic. Why do endocrinologists and other mainstream physicians have such a low success rate with Hashimoto's disease? Reason number one can actually be summed up in just a few words. An endocrinologist, when asked about a particular new diagnostic tool or treatment, will say, I find insufficient evidence that XYZ is effective. What they mean by that is that there are no large randomized double-blind placebo-controlled trials that show evidence that a particular proposed treatment or diagnostic criteria has been proven to work statistically for most people. This kind of trial has become synonymous with evidence-based medicine, and all other types of evidence are considered less valuable. There are also no FDA-approved drugs that specifically treat Hashimoto's disease, and little, if any, pharmaceutical research being done to find new ways to treat Hashimoto's, since the current guidelines-based use of Synthroid or levothyroxine is successful, and I'm using air quotes here, according to the TSH, that is, for the majority of people. Doctors who feel bound by the mainstream medicine's guidelines want strong evidence of the effectiveness of a treatment or diagnostic tool before they're willing to try it. This kind of research, a randomized clinical trial, when it has been done, is admirable in general and very desirable, particularly when it is confirmed by follow-up studies from different researchers that show the same kind of findings. But there are several kinds of reasons why this research frequently isn't available to answer that particular clinical question. Number one, it's expensive. Most of the money spent on clinical research these days is funded by big money, either pharma or by the NIH, and conducted in big academic institutions with big reputations. And now that the NIH and their grants for science are being gutted, we're basically left with big pharma alone, unless some charitable foundations that are private step up to fund research. Much of this data and this research is driven by an agenda by the companies who stand to profit from the positive results, or by a researcher or institution that's out to prove a particular point rather than ask an open-ended question. An example of this was the Women's Health Initiative. So the principal investigator had gone on record years before the study even started, stating that he was out to squash the use of menopausal hormone therapy for reasons of his own that were not stated. This study cost nearly $1 billion and was designed in particular to filter out the known benefits of hormone replacement and focus on women who are being given it for unproven heart benefits. So the subsequent breast cancer scare that the study, particularly this particular investigator, created, set research and medical care for menopausal women back at least 20 years. Reason number two, randomized clinical trials need to be really simple, usually only testing one variable at a time. Is medication A better than a placebo or better than medication B? With control and randomization for every other variable, such as diet, the weight of the participants, and whether they've been on similar medications before. Reason number three, randomized treatment studies have to have lots and lots of participants and control groups in order to actually prove that some treatment is effective in a statistically significant way that may be or may not be meaningful clinically. And if they're asking the wrong question, it can make a treatment look like it doesn't work. And if you're in the minority of people for whom the mainstream diagnostic measures and or treatment are not as effective, you may be out of luck. And that's the case for a lot of people with Hashimoto's disease. Also, it's not ethical to withhold a treatment once it's known to have a health benefit. So, for example, you can't give a placebo to somebody you know needs thyroid medication. So it's hard to find a control group for that. So no randomized trials versus placebo can be done to people who already have an abnormal TSH. So here's the example. When they ask the question of which treatment is more effective, levothyroxine or natural desiccated thyroid, which is an animal combination product, it matters who's being included in the treatment group, like the severity of the symptoms versus their lab values for TSH only, versus also checking their free T3 or maybe even their reverse T3. It also matters how often and at what dose the treatment is administered and how they determine whether the treatment is working or not. By most of the criteria which have been studied, levothyroxine is the clear winner. Until you ask the patients, that is, and then a very large subset will say that the natural desiccated thyroid is better. Now, that study was actually done, but the doctors are still scratching their heads about why that was the case and how to prescribe it and how much. I have lots of ideas about that and have discussed those in other podcast episodes. That's a topic for another day. And keep in mind, the entire treatment group in a randomized controlled trial is generally going to be getting the same dose of a medication in most of the studies that are like this. So think of that Women's Health Initiative, for example. Everyone who was given estrogens got the same dose, and no one's blood levels were checked either before, during, or after the study. That would totally not be approved today. Clinicians who treat thyroid patients, particularly Hashimoto's disease, know that the requirement for thyroid replacement is all over the place. Why else are there levothyroxine tablets ranging from 12.5 micrograms all the way to 300 micrograms? So how are the study participants going to be monitored for the effective treatment? If you just use TSH, it still looks like TSH is that levothyroxine is probably the best treatment. But if you don't ask the patients how they're feeling, you don't know whether it's actually helping them or not. Anyway, high quality evidence of the kind that academics and academically inclined endocrinologists generally insist on tends to lag newer treatments or diagnostic modalities by a minimum of 17 years or sometimes 30. Even when research has been done, it takes a really long time for that information to make it into actual clinical practice. Private practice physicians who don't have academic support, who try to publish clinical observations or smaller studies, are frequently dismissed as not relevant if they do not have academic prestige or money behind them. And those in positions of prestige may not be able to rock the boat, so to speak, without endangering their status. The second reason it's so hard for an endocrinologist to manage Hashimoto's disease is 4 words. First, do no harm. As physicians, we all took an oath, the Hippocratic Oath, not to do something we fear might be harmful, like giving thyroid medicine to somebody who doesn't actually need it, or giving dangerous T3 when T4, quote unquote, works just fine, or seems to work just fine. So there are many practitioners out there who are not physicians and who are just fine giving you a treatment that might turn out to be harmful as long as it feels good to you in the short term and makes them money. Bone loss? Nah, you'll be long gone from them before that shows up. Heart failure? Not their problem. Buyer beware. But clinical experience is generally not emphasized anymore as a legitimate way to validate new or old methods or treatments, which are generally ignored unless they come in the form of a recent article in a prestige journal. So very few private practitioners have the budget or clout to publish data in a way that makes it palatable to big publishers. So I'm not saying this gridlock on new ideas is unique to endocrinologists. I mean, think about Dr. Atkins, who was ridiculed in the 1970s for his Atkins diet right up until his death in 2003. I'm wondering if he's sitting up there somewhere watching and laughing at us as his ideas are finally vindicated and a low-carb, high-fat diet becomes the diabetic diet of choice. Anyway, I wasn't intending to rant. So how do my training and methods differ from an endocrinologist? Well, I'm a surgeon. Surgeons like to do things. We like things that work. If a thyroid has a cancer in it, take it out. Got a trauma? Put the patient back together any way you can and write about what worked later. Stomach's making too much stomach acid? Cut the nerves. That was a thing right up until it was determined that peptic ulcers are actually caused by a particular kind of bacterial infection that could be treated by an expensive drug, by the way. But as newer methods for blocking acid came online, it became a very infrequent surgery that is not really done anymore because it didn't actually work that good. It's still interesting to me, though, how very few doctors are even suggesting that persistent GERD and the myriad of gut problems, since I'm on the topic of gut, out there today might have an unrecognized thyroid insufficiency as their source. My point is, surgeons as a group are fairly quick to look for new ways of doing things when the older ways seem to be failing, like giving allergy shots for patients who have chronic sinusitis to clear them up, and also in considering an individual person's situation when they fail an initial treatment or whether or not to try a treatment. In thyroid treatment, the old way fails and doesn't help patients feel better about 20% of the time. 20% of people who get put on levothyroxine alone will fail that treatment and not feel well despite a normal TSH. And that is not even considering the many, many people who have Hashimoto's disease or other thyroid symptoms who have been told there's nothing we can do, your thyroid labs are normal. The third reason endocrinologists have a hard time with Hashimoto's is that Hashimoto's disease and hypothyroidism are viewed as two separate diseases. So Hashimoto's is an autoimmune attack on the thyroid gland, and endocrinologists generally don't treat autoimmune diseases. Of course, it can be triggered by any number of stress and inflammatory conditions, and they have a really simple way to deal with it once your thyroid gland has been destroyed. Give you levothyroxine. But the fact that it leaves many people feeling poorly is a puzzle to them, but not one they really have time to figure out. So much so that many of them don't find validity in even knowing whether Hashimoto's is the why behind the symptoms. So this actually does seem to be changing finally, and many endocrinologists that I speak to even agree that some people tend to seem to do better with T3, although they don't really have an effective protocol for figuring out who that's going to be and then what to do about treating them with T3 because of reason number one that we talked about above. But also, treating autoimmune diseases through non-pharmaceutical means is something that mainstream medicine as a whole is ignoring. This is the exclusive domain of integrative medicine or functional medicine. Even functional medicine mostly goes off the deep end and strays too far from what has been proven helpful, throwing herbs and supplements and other treatments that are out of any kind of legitimate medical practice at the problem. And Hashimoto's, unlike many autoimmune diseases, as of today, doesn't have any drug treatments, any big pharma drug treatments, FDA approved, in the pipeline. So the way I do things is kind of a happy medium. It's based on science, and it doesn't throw out the baby with the bathwater. An abnormal TSH is a great way to identify people who need thyroid treatment, but in my practice, it is not the only test that's needed. People who come to see me generally have already failed other testing and treatments. Levothyroxine is not the only way to treat low thyroid, and there are lots of legitimate ways to help stabilize a damaged thyroid gland and calm down the autoimmune attack. Generally, both approaches are necessary to get people feeling better. And much of that has to do with the relationship of thyroid to the other important hormones. Now, I'll talk about that more in future episodes, but for now, if you think you might need what I offer, my website at www.danagibbsmd.com has a link for a free discovery call, and I have new patient slots available and open now. Bye for now. Talk to you next week. Thank you for listening to this episode of Beyond the Thyroid. If you found this information valuable, it would mean so much to me if you'll take a few seconds and give the podcast a 5-star review. It helps other people who need this information find the show, and it's really easy. Just search and click on the name of the show, Beyond the Thyroid, and scroll to the bottom to ratings and reviews. I truly do read and appreciate every one. Remember, when it comes to hormones, there will always be more to discover. So follow the show so you get the next episode as soon as it's released. And if you or someone you care about needs a caring doctor to help figure out how to heal hormone problems that other doctors have dismissed, check out my website at www.danagibbsmd.com. And if you're not a physician, please keep in mind, while I'm a doctor, I'm not your doctor. The content of this podcast is my opinion, and it's for educational and entertainment purposes only. This is not meant to be individual medical advice, and you should consult your own physician for any medical issues or diagnoses that you may have. I look forward to continuing this journey with you beyond the thyroid.